Okay, let's switch gears. Corey said before that you said 25 years. I don't know if it's that much that we haven't made progress in stage 3, chemoradiotherapy. Let's talk about small cell.
Wow.
I think that might be the record where we haven't seen an advance.
I think we made more advances in locally advanced.
Yes, than small cell.
Than we did in small cell.
Yeah.
We made
In that
some.
same time
we made
period.
some.
Yeah, so thinking about small cell and extensive stage disease, Tiziana, we have recently had a new approval and I would say another practice-changing phase 3 trial, IMpower133.
Yes, so IMpower133 is a phase 3 trial investigating the addition of atezolizumab, a PD-L1 inhibitor, in combination with our standard chemotherapy, carboplatin/etoposide. And this study enrolled patients with PS performance status of 0 to 1 and patients who had treated stable brain mets. And I bring that up because certainly we know that our small cell population is different from that population. We have a lot of patients with performance status that is 2 or greater, or who come in first with brain mets. But in any case, this study allowed these patients that had PS of 0 to 1 and stable treated brain mets to be enrolled, and they were randomized to either carboplatin etoposide atezo versus carboplatin etoposide placebo. And this was actually a double-blind study. And in this study, we saw the primary endpoint of overall survival that was positive. There was a 2-month improvement in overall survival. We also saw a PFS benefit. It was about a 1.5-month overall benefit in progression-free survival. It statistically met primary endpoints of OS and PFS. The toxicity of adding atezolizumab seemed to be not too much different than what we would see with carboplatin etoposide, which I think was reassuring. I think we all had concerns of, patients that have perineoplastic syndromes, would immunotherapy be an issue? Again, patients with perineoplastic syndromes were excluded, but we know that sometimes these go undiagnosed. And we didn't really see a major problem in terms of immune-related toxicities beyond what we would see with a combination of chemotherapy and immunotherapy. This study didn't really have enough tissue to make any real conclusions about, is there a biomarker there? They explored blood-based biomarkers, again, looking at TMB in the blood, and they really didn't see any signal of improvement in one population or another based on the blood TMB. So it's an interesting trial in the sense that, yes, we see an improvement. I think it's something to build on. I think it made a lot of sense to use immunotherapy. It's still puzzling why the benefit wasn't greater, but I think future studies can address that, and certainly building upon that platform is how I see this moving forward.
I guess because we've had such a drought in small cell that anything that was better is perceived as a practice changing.
And it's immune therapy.
And it's you're right, and that's my point. I would have thought that immunotherapy would have been much more impactful in small cell. I'm not quite sure why I might have thought that, but certainly the clinical data has not. I mean, I know nivolumab has a 3rd-line indication, but that 3rd-line indication is no better than topotecan. In fact, in the 2nd-line setting when it was randomized against topotecan, it is no better than topotecan. So, Paul, your thoughts on that issue?
It's a strange space that has lots of different trials that have been conducted in the maintenance, like switch maintenance state. As you had mentioned, Checkmate 331, which is a bona fide randomized trial of nivo versus dealer's choice chemo, which technically was negative. It was negative, but it's, to me, IMpower133. The benefit seems consistent with what you might get if you just gave someone 2nd-line immunotherapy, either nivo or pembro, right after they got carbo-ETOP. Because each of these studies in the 2nd-line or maintenance space, even the ones that were negative, have median PFS values about 2, which is the improvement that we saw. Overall survival, of course, is impossible for us to adjudicate on cross-trial comparison, but And there was response rate activity for pembrolizumab in the 2nd-line setting. This is 19%. And for me, one of the concerns about everyone getting atezolizumab up front now is that this impairs our ability to do trials to find better immunotherapy combinations for these folks, because now everyone is going to be in this sort of immunotherapy refractory space. The biology has now changed, making the science a little bit more difficult to figure out.